Good morning, everyone. My name is Vivian Boucher. I'm an interventional radiologist here at Mount Sinai. Thanks so much for joining us for another case for Treat Live. I'm very excited to have a co-moderator here with me. Sam Mouli from Northwestern is joining me remotely, and we're going to have a great discussion about this case. So, Sam, we're going to be talking about prostate artery embolization. That's the case we're doing today. Sam is very prolific in this field. He's the author of the recent updates from SIR on prostate artery embolization. Very excited to have you. Thank you for joining us and looking forward to the discussion around this case.
Thank you for having me.
So maybe we can go to the room and Aaron Fischman and his colleagues can be introduced.
Thanks, Viv. And thank you, Sam, for joining us. We're here at Mount Sinai West again. Welcome back to everybody. This is the August version of our Treat Live Symposium. To my left here is my colleague and partner, Dan Shilo. Behind me is our esteemed PGY6 resident, Dogan Polat. And then over here behind him is Jackie Brenner, our esteemed medical student. We also have Eladio and Norika, our nurse and tech in the room, and we have an anesthesia team as well. So without further ado, we have a very interesting case. I'm going to have Dogan present the clinical vignette for everybody.
Good morning, everyone. My name is Dogan. Today, we're going to be talking about considerations for repeat prostate artery embolization. Our patient is an 80-year-old gentleman with BPH and lower urinary tract symptoms presenting for a repeat PAE. He had an unsuccessful PAE attempt at outside hospital back in 2017, then was referred to our clinic, and he underwent a PAE with microparticles in December of 2017. With immediate improvement in urinary flow and symptoms, which remained improved for several years. Symptoms recurred about 3 years ago and had a green light laser procedure at outside hospital with a marginal benefit. And about 3 weeks ago, nocturnal urinary retention occurred, and evaluation in the emergency department did not require catheterization after an extra dose of Cialis improved urination. Since then, urination has continued, but bothersome symptoms persist with nocturia 3-4 times a night and marked difficulty initiating the stream as well as daytime urgency. He also had intermittent hematuria, which occurred for a couple of weeks before the emergency department visit. His current medications include Cialis 5 mg and statin of 20 milligrams. He reports no sleep apnea and no GLP-1 use, which is relevant for our anesthesia purposes. Imaging outside MRI with prostate volume of 114, and unfortunately, we do not have the images with us today. And his scores, IPSS was 26, quality of life 5, and SHIM of 15. And plan is to repeat PAE with n-BCA if anatomy allows. Here you can see the initial CT before the first PAE. From 2017, you can see a very vascular enlarged prostate, which measures about 120 ml. And on the right, you can see on the sagittal view, the intravascular prostatic protrusion, significant. This is our initial procedure back in December 2017. Sorry about the typo. This shows a left internal iliac angiography. You can see with the red arrow, the prostate artery originating from the internal pudendal artery, which is type 4. And blue arrow shows the anastomosis to the right pudendal, as well as it comes back to the left pudendal, which is off screen on this image. Here we can see the catheterization of the left prostate artery with significant contrast blush of the prostate. We also have a Foley-in, which helps us to landmark where the prostate is. And you can see the anastomosis to the other side in the delayed phase. Next slide, please. This is a cone beam confirmation of the left prostate artery. You can see the contrast only limited to the left side only. Here, we went all the way in distally and catheterized that anastomosis. On your left, you can see it goes all the way to the internal pudendal on the other side, and it also connects to the left internal pudendal in a retrograde fashion. And we coil embolized the anastomosis, and you can see the run after the coiling, which shows complete or near complete occlusion. And then we went to the right side. You see the right internal iliac angiography with RAO of 40 degrees. And we initially catheterized the vessel that is shown with the green arrow. And the angio run afterwards clearly shows that this is like a middle rectal branch, which we confirmed with a cone beam CT, and you can see the blush in the CCR. Then we went up to that vessel that is shown with the green arrow, the curly vessel with a little bit of a different oblique, RAO 35 as opposed to 40. Next slide, please. And the angiogram shows significant blush in the prostate as well as the anastomosis, which is going through our coil, which is also confirmed with a cone beam CT. And we use 2 mLs of 250 micron microparticles on the right side and 6 ml on the left. Here you can see the final angiogram, which shows the complete stasis of the prostate artery. And today our plan is to perform bilateral internally like angiograms and do a PAE with n-BCA if prostate arteries or collaterals are open. And this is our lovely group. Thank you so much for joining us.
What's that?
I already love this case because you see how things were performed in 2017, and we'll kind of get an evolution here from then till now. I mean, first off, the number of cone beams. So that's a question, are you performing cone beams these days when, it's obviously you're doing a number of them at that point.
I'm sure Sam is going to have a lot to say about that, but a couple of things that we're doing differently. The cone beam, I think, is very useful. But again, that was 9 years ago. That was very early on in our experience. Since then, we've done thousands more cases. And so identifying vessels is not so much of a challenge anymore, as you know. So there are other reasons to use cone beam, and I'm sure you and Sam can discuss that. Also, the Foley balloon was something we were doing 9 years ago, which we stopped doing pretty soon after that, but that does help identify the prostate in some scenarios. And then the use of coil embolization with particles, I think, is more of a necessity than it is with glue, which we'll talk about as well. Before we start, I wanted to show you guys what we've done so far. So we have a transradial access. This is a very healthy younger side patient with good arteries. The wire, this is a Benson wire, went right down the descending aorta. And we were lucky enough to hit the right side first. We usually pick whichever side the wire goes. This is a 130 centimeter penumbra diagnostic catheter. It's got a burn tip, and this has been our preferred catheter for PAE for many years now. It happens to be the right combination of stiffness and soft tip. It allows us to cannulate very distal vessels in the internal iliac. And so this is just getting into the internal on that side. And then here's the first run we did. And this is, I think, very interesting because we were talking about repeat PA before. And at least 40 to 50% of the time when you do a repeat PAE some years later, we often see wide open prostate arteries. So this is the first angiogram, and I'm curious to see what you guys think of it. Any thoughts so far? I'm just going to scroll through it a little bit more. We can identify pretty much all the vessels here. I'm going to see if I can put the pointer up, but you guys can chat and tell me your thoughts on this angio.
Well, if we say that the coils are roughly where your target was previously, it's very unimpressive. You don't really see anything going anywhere near those coils.
Right. So these are the coils that you're talking about, right? Right. You guys can see my pointer. Is that, yeah?
No.
Maybe? No? Okay. That's fine. But that was on the other side, pudendal anastomosis. But yes, that's in the region of the prostate. We see a normal obturator artery. We actually see a retropubic branch of the obturator that's flashing if we scroll through in and out. So that probably has inflow from the other side. And we see a pretty dramatic superior vesicular artery. And then we see a very big pudendal artery. And as Sam pointed out, we really don't see that vessel that we saw previously that we had embolized. It's probably there in the mix behind that rectal artery. And we showed those images before. But not a lot of prostate perfusion for somebody that has 112 cc gland. That's very vascular. Any other thoughts? Do you guys agree, disagree?
Yeah, totally agree. I mean, I see the vessel, but it's certainly more diminutive than it was. And there, even on the delay, you're not seeing really any prostatic blush if you held it out, right?
Correct. So a few minutes ago, we decided that we would just take a peek at the other side because we didn't really like the way this side looked. And I'll just play that for you. One sec. So we just take this catheter, we bring it back, and we can do this pretty easily, sometimes without a wire. Flip it over to the other side. This is a big advantage of doing transradial access. You can see just with a little contrast and good arteries. Thankfully, he has very good arteries, which always makes these cases a lot easier. And I think that's a big predictor of success is good arteries and non-atherosclerotic arteries. And so we just popped right into the inferior internal iliac artery. So here's the angiogram that we did. And what we're seeing here is a wide open prostate artery. In a lot of ways, it actually looks more patent than the previous angiogram from 9 years ago. And so my thought on that is, number one, if the prostate's being supplied primarily from the left, the right's not perfusing very much, this artery is going to hypertrophy. So in somebody who has reperfusion through the main prostatic artery only on one side, that artery becomes the dominant supply. So then what we did was we took this base catheter, which is, one of the big advantages I mentioned before is getting into the internal iliac from above, but you can actually take these catheters, since they're so soft, and really drive them very deep from the wrist into the both pudendal and obturator arteries very easily. And so this was the initial angiogram. And I think this is quite impressive of how vascular this prostate is 9 years after embolization. You can even see it's probably supplying both sides of the prostate, although we didn't do an AP yet. We will. But what's also interesting is if you look at the pudendal, we see the pudendal anastomosis just proximal to the penile artery going right up into the prostate as well. And interestingly, the coils that we put into the collateral there look like they're not occlusive. And either that's perfusing retrograde, it's possible it's perfusing retrograde from the pudendal collateral, or it's just flow through the coils on the antegrade side. So a lot of talking here. I wanted to hear what you guys think about this angiogram.
I think, like you said, doing an AP is a good idea just to see that you're actually supplying the entire prostate via this single left side of prostatic artery. So that would be my next step. And then I'm wondering how folks would deal with that collateral.
One of the things that I was thinking about, we know we're going to get into this prostate artery very easily. It's a type 4. It's very close to the catheter tip. We should be able to cannulate it rather quickly. What I think is probably more interesting about this angiogram is that pena cava or pudendal collateral coming off the pudendal. So normally in those scenarios, we cannulate them if we can, and we try to embolize both the prostate and the pudendal collateral. One of the catheters that I really like for that application is the angled burn tip 2.0 TruSelect. Do you guys have a preferred catheter for that?
Yeah, that's my workhorse for a lot of getting into these distal vessels, and a really soft 014 wire to hope to cannulate it. If it's a really tight angle, which often it is, this looks a little bit more favorable. Then sometimes you can get into it through the prostate and come down. So if you get lucky that way, I try to coil it off. Less so for concern of non-target. I think if you have a good pudendal like this gentleman has and good inflow, it's probably protected, pushing everything back towards the gland. But this guy's a repeat for you, so you kind of want to make sure that it doesn't recruit from there. I've gotten burned a couple times where I treat both sides. It looks great, exactly like your patient. A few years later, they come back and it's a giant vessel from the distal internal pudendal feeding the entire gland.
I mean, I think the best way to think about this, Sam, is if you see a vessel supplying the prostate, you should embolize it. That's really the simplest way to think about it. I'm actually really happy today that we have the new 2.6 French TruSelect. So it may be a little big for this vessel, but I wanted to sort of test it out and see how far we can get it. And my thought is, and we'll talk about the differences between this and the 2.0 TruSelect in a second, but if we can do that first, we can go back into the main prostate second and then treat the main vessel.
I think in this case, we could potentially go in from either end. I think it would be possible. I don't think there's a wrong choice here.
Yeah. So if you guys can zoom in on my hand.
Is that straight tip or burn? Sorry, I missed that.
Yeah, so my favorite catheter for that application is the 2.0 burn tip. If you guys can zoom in on my hands here, I'll show you what we have. So through this microcatheter, this is the 2.6. It's actually a straight tip. And I have a 0.16 Asahi Meister wire, which I like 0.16. This has been my go-to for a while now. just because the tip is so shapeable. And I think for delicate vessels like this, it might be advantageous. So Dan's going to pull the wire back and I'm going to show you the tip of the microcatheter. We can zoom in on it. This is a straight microcatheter, but the advantage of this microcatheter, and again, this literally just came out, we can shape the tip of the microcatheter. So I can shape this microcatheter the same way I would shape a wire. So I'm going to use the shaper here.
Put it like it.
Yeah, if you guys can see it, that's better.
Yeah.
Very straight. So I'm going to shape it probably to make it almost like a burn tip. Now I can make any shape I want. But I'm going to try to keep this really close to the tip to see if it holds its shape. If you guys can see here.
Yeah.
All right. You guys can see that? So I made my own shape. And so we were joking the other day about years ago, Harold Mitty told me one of the rotations for or for radiology residents was catheter making. Back in the 70s.
I think we have a steamer somewhere here.
Yeah.
If anybody has a kettle.
Sort of a pretty amazing innovation. And the nice thing about the way that this works is it's big enough that it's going to be able to do high flow injection. It's also going to hold its shape when we get in here. So I don't know that it's going to get into that tiny vessel, but I figure why not give it a shot? So I'm going to come over here. We're going to go down that pudendal to start and see if we can get into it.
And Aaron, your plan is to embolize from there, right? Not just proximally occlude it, correct?
Well, we'll see what it looks like. I mean, I think we can probably put a little bit of glue in there. We could put we can decide once we're there. A lot of it's going to depend on the flow.
Hang on a second.
I should have the roadmap up. Let's see.
Yeah.
Yep. I'm actually in the prostate artery already, but we're going to skip that for now. Yeah, let's pull back.
Yeah, I've had the opportunity to use this a couple times. It's a great catheter.
Yeah. So Sam, tell us about your experience and what you like about it.
So, the origin that we all hate to deal with when we have these cases is the type 1 origin off the superior vesicle, which is often very difficult to cannulate depending on if the patient has a lot of atherosclerosis or really tight angles.
So wireless.
And my go-to
Just float the catheter.
Yeah.
is a J-shaped microcatheter. And you can put a J shape on this, just like Aaron just shaped this to a burn. And it holds its shape really, really well. You can almost primarily drive into it like he is with a J shape.
Yeah. I mean, we're
using the wire. I think the catheter might have just gone on its own.
Yeah. Sometimes the wire gets in the way.
Yeah.
I'll be honest.
It finds all these small little branches.
From a radial approach, I can take this base catheter and I have about, 7 centimeters. I can actually put it deeper into the pudendal so I have more running room with the microcatheter, which I just did.
You want to do a little puff from here?
Yeah. Can. We'll do a little DSA here.
Here you go.
Why don't we zoom in a little bit so we can see a little bit better?
Thanks so much.
Yeah, let's go a little lower. Yeah. We're pretty close.
Yeah.
This here.
Yeah. Okay. Yeah. Interesting. Yeah, we can talk about how we want to embolize that. Let me see that wire real quick. It's definitely filling a lot of prostate. It's also filling the opposite side.
Yeah.
So, this is a great example of how recurrent PAs go. We usually find collaterals, and this is an example of that.
You want to pull back a little bit on the micro? Maybe it's a little,
This is a big catheter, 2.6, but it's tracking amazingly well. These vessels are actually very challenging sometimes to navigate. The other thing we have is nitro on the table, which we might have to utilize.
Yeah.
There we go.
There you go.
Is that it?
Nice.
It might be it.
Close. If it's not, it's worth checking out.
Yeah,
Yeah, I think that's it.
yeah.
No.
Mm.
Yeah,
Not it.
let's just have one.
No, there's a couple of ratty vessels there that I think might be tough for a catheter to speak to get by. Maybe a little nitro.
Yeah, let's do a little nitro here. So we have a syringe here that's filled with nitroglycerin and verapamil together. The verapamil can burn. Just everybody knows. So we just inject it slow.
So I saw that he was on Cialis as one of his medications, and I found that those patients, you need a lot more
A
nitro
little run here.
Is that right?
when we do these cases. I feel like their vessels are more spasm prone because they're chronically on it, you know?
That's a great, interesting point. I never thought of that, Sam. That's why you're here. What other interesting tidbits have you found about Cialis?
Basically, I've been telling my patients if they're on it before seeing me for the case, we have them hold it for a week so that, you know,
Interesting.
they don't have all this spasm and such. I don't know. It's just anecdotal. There've been a couple of cases where the vessel looks fake. You touch it once and then, you know, you can't see it again. And I'm just super frustrated. So I call my nurse and tell her, just take him off Cialis forever, you know? So, but I think a lot more patients are on it. A lot more patients are also on testosterone, which might increase our rates of recurrence as we do more of these cases.
Yeah, that's for sure. That's another interesting point. I don't think we're that close yet.
No. Do you want to try a different wire?
Yeah, maybe we'll switch to a different wire.
Switch to an 0.4 fathom.
We could try an 0.4 fathom. What would you guys use here to get into that?
0.4 fathoms.
Yeah, let's try that.
Move to
All right.
0.4.
Let's see.
I'm also going to go to 8P and see if that helps a little bit.
I'm going to pull back a little bit, do a run.
Yeah.
Do the nitro dib. Yes.
How often are you guys doing repeats? And what do you think the actual recurrence rate is, Sam?
I think it's probably 20%. My number is probably 15 to 20%. I got a guy just like yours, 8 years out, who's coming in another week or two. So it'll be interesting to see what his vessels look like. I think it's probably unavoidable to a certain degree, but maybe with your using glue,
Okay.
it'll be a more thorough embolization than particles. It's shocking how little those coils did, because I'm coiling a lot of stuff these days.
Yeah, I know. It's not great. We have a lot of spasm here. It's right there.
Yeah.
This is a tough vessel because it's so small. I'm going to do a DSA and then we'll take another map. But it's also great to see the cavernosal blush here, guys.
Yeah.
To see so much cavernosal blush.
I think that shows you the way out. You definitely have a little bit of spasm there.
Would envy that cavernosal blush, right? We all want that. So this is an
0.4 fathom.
Yeah, this shape is a little. See if we can reshape that. So do you like the 0.4 fathom as like a go-to wire?
Yeah, that's my starting wire is the 0.4 fathom.
Think you'd have an easier time with the 2.0?
I don't think that's the issue here because it's the wire that's not going, not the catheter.
Yeah.
So I don't know. So maybe tracking into the actual artery.
Yeah, that's what I'm just not.
But that's the real test. This is not the catheter. It's just spasm.
I think the roadmap is a little deceptive here. I think there's a lot of spasm there. Yeah, getting more distally into that vessel
That's
with the microcatheter could be tough. Yeah,
challenge.
It's going to essentially be the size of the.
Yeah, it's just
Maybe even a little smaller.
Wire shape is not ideal either.
Yeah, so we say like 20% at 5 years. Do you think, though, these patients, especially the ones who you're seeing, and you're seeing more and more young patients, that the natural history, if you just wait longer, that they're all going to recur to some degree?
I think so. I mean, I'm seeing a lot more 50-year-olds in my clinic
Do a little more
in the
nitro.
last few weeks, which is terrifying because it's not far off for me. And I've been telling them, on a long enough time scale, we expect it to come back, if you live another 30, 40 years. So, but I think that the trade-off is, they'd rather not have sexual dysfunction and all the side effects of, all the surgical therapies. So they're willing to take that risk.
What do you think the recurrence rate is, Viv? You want to talk about the recurrence rate with glue versus particles? Not that we know yet, but let's.
Yeah, I mean, what we sort of think in terms of the ones we've seen and the series that we've looked at in our institution, that we're getting more durability and more significant ischemia with liquid. So, I think we believe that that's going to translate to a lower recurrence rate. But again, in the long term, I agree with Sam that probably a lot of patients may, if they live long enough, need more than one therapy, and we should be or more than one treatment, and just make sure that they're kind of aware of that cost benefit compared to other therapies that are out there.
And I would say, except for completely taking out the whole prostate surgically, everybody's probably going to recur at some level. I've had patients that have had HOLEPs before, where everything's supposed to come out, and they've had recurrence, and I had to retreat them. So I don't know that anybody has a perfect option for them. It's just, exactly what you said, kind of weighing the risks and benefits of the various treatments and deciding what matches their desires and their lifestyle. What I'd love to hear, though, is, from you guys, since you have the most experience, is how we saw how Aaron was doing particles, 7, 8 years ago, 9 years ago. How has glue evolved since you've been using it for many years? How have you changed your techniques and such?
Well, we want to get deeper penetration, and that's a really important point. I think the deeper you get into the gland, the less likely those intraprostatic vessels can recruit. Okay, so I think I see what the issue is here. This is the opposite oblique. Let's go back to the Asahi wire. It looks to me like the bifurcation where we're going into the penile artery was going, at least on this image, is going off to the right, and the prostate artery that's coming off the cavernosal branch there is going up. Not to minimize this blood vessel, but this is a treacherous vessel to embolize regardless of what embolic agent you're using. A lot of people that do these pena cava type branches will not use particles here because the particles are very hard to control. A lot of people will just put a coil here, which I think is completely reasonable. I've had a good experience and good luck using glue here, but it is a little bit more challenging than in the native artery because you really have to be careful. You're not trying to get distal penetration.
This is what you need to see. That's the oblique.
This is a better view.
Yeah.
Yeah.
Will you track?
Okay. Well, that's not where we're going. We got to go up.
Yeah, I think we got to make a pretty sharp turn there.
Yeah, these do another run.
Yeah, do like a different oblique.
Change the shape on your.
We could do whatever, but I don't want to take the microcatheter.
No, I would take the wire. I'll see what we are. Yeah, I think we made the right turn.
All right, we'll take.
No, but to your point, Aaron, you can control it with glue in a way you just can't with particles. Obviously, you can coil off vessels, but you can control the distal penetration, and that's allowed us to really.
I'm actually very impressed with this catheter, just being able to get this far. I would never in a million years take any other 2.4 or 2.6 catheter into this artery, but this is tract. I mean, besides the fact that we haven't hit the actual artery we're targeting, this is amazing distal catheterization. Yeah, interesting. I thought that was the one going up, but we're past it. So the origin is probably 90 degrees, which is why we can't see it.
Yeah.
Yeah, I think we're past where I need to be.
There it is. See it right there?
Yeah.
Straight up. So it's like, it's not where we thought it was. We're going to go back to the Asahi. So it looks like we're right in front of it, and it's going to track up. And then the branches that go distal are the cavernosal arteries. And the penile artery is more proximal. Let's go to this is the Asahi.
Yeah.
Aaron, can you talk a little bit about your dilution and if that's evolved over,
Yeah,
regards to penetration.
When we glue the prostate artery in a second, or hopefully when we're finished with this vessel, I'm going to show the mixture. I think anywhere between 6 to 1 and 10 to 1 is reasonable. I sort of split the difference and do 8 to 1. It's very simple to use a half cc of n-BCA and 5 cc's of lapiodol. That way you're not wasting too much. And then you end up not even using all of that in some cases. We got the image up? Yeah.
Yep.
Nope. Honestly, if we don't get this vessel, it's not the end of the world.
There's a world we could actually get it from the prostate itself.
Yeah.
We'll have to do that run and see, what that path looks like.
Yeah, but you see that, the difference between glue and particles is that we don't typically find the need to coil anymore these anastomoses because it's very hard for an adhesive agent to go all the way through the anastomosis if you control it well. So, we'll see. But yeah, 8-to-1, Vivian, is sort of what I've been using. What have you been using?
Mm-hmm. I'm still a little, I don't use occlusion balloon catheter as much as you do.
That's it.
Yeah.
So I go a little bit thinner to try to get a little bit more distal penetration. So I'm more like 10-to-1, but
Will the wire go any further?
Maybe. No. You think the 10-to-1 goes that much further than 8-to-1? I don't really know the answer.
I don't know. I have to do more cases with 8-to-1 to see if there's really a noticeable difference. But I try to
And what is
drive my
your-
base catheter, into as distal as possible to kind
Lateral
of
here.
create a little bit of a wedge effect so that, you're almost pushing the glue as if it's occlusive. So that's sort of what I do when I'm not using a balloon occlusion catheter.
How do you gauge the force and injection speed that you're going to eventually utilize?
Well, that's
Well,
sort of, it depends. That depends on the operator and how much experience you have with glue. Right, Biff? What do you think?
And it depends on if you
That's not
feel
it.
like you're occlusive and you're pushing it, then you can push kind of faster and get it to, you're not necessarily using flow as much in that instance.
You think this is the artery? What do you guys think?
I think so. I think you're just tickling the origin.
Yeah.
Maybe it'll just pop up.
Sometimes it does.
Can you get that TruSelect closer to give you support, or is it kind of maxed down?
No, we can get it. I just can't. I can't push it anymore. Interesting. Yeah, it just doesn't want to make 3 turns, this wire. So, the other option is to use a Fathom 16 as opposed to an Asahi 16. Sometimes that gives you a little extra support, which may actually work. But I think that this vessel is just so small and there's just too many turns here. This doesn't want to get in there. So I think what we're going to do is we're going to embolize the prostate artery, and then we can decide if we want to come back to this at the end. Unless you guys have any other thoughts. I think it's a good plan.
It sounds reasonable.
Yeah, because look, if that wire is just not going on. All right. So we're going to go back. I'm going to take this catheter out. We're going to just do another run through the base catheter, and then we'll go right into the prostate, and we'll show you guys the mixture and how we do the embolization. This guy has one of the juiciest prostate arteries we've seen in a few days, actually. In a few days.
Which is great to see in a repeat case.
Yeah, I know. There you go. All right.
Looks like
There's a couple tricks that we're gonna show you guys on how to do the embolization. But I want to just get in there and we'll do the run and then we'll talk about it. Sam, have you tried the glue yet or no?
No, waiting for the. I got a case 2 weeks. I think I'm going to use it on. So as a background, I came and watched Aaron do cases last week. Very educational. We did 7 in a day, which was amazing, throughput alone. And so lots of tips and tricks that they have that I'd like to adopt to my own practice. So, but as you said, it's an experience thing. So you got to kind of get a feel for the force and balloon occlusion, not balloon occlusion, what the right anatomy is to try it out. And so just waiting for the ideal case to manifest.
Well, one of the nice things about balloon occlusion is that you can take your time with the embolization a little bit more.
Mm-hmm.
With the end hole catheter, you do have to be conscious of the fact that if you go too slow, the liquid will set too quickly.
Yeah, you're in.
This catheter really tracks amazingly well for a 2.6. I can't even believe it. Okay, so we're gonna do a run here. Take a look. But this angiogram is gonna look. These are the kind of the angiograms that Sam dreams about, right?
I think we all do for prostates.
Yeah.
And for the purposes of the liquid embolic, spasm might be as good as a coil down there. So
Exactly. I'm going to inject slow and then fast. So what do you guys think? Did it go through the coil or did it go somewhere else? It looks like it went through the prostate, through a different vessel, and then into the anastomosis.
Yes. Right. Looks like through the bottom.
It looks like the coil was effective in the vessel that we embolized, but obviously the prostate didn't care and connected itself to the pudendal anyway. I'm not worried, honestly, that if we inject glue from this spot, and this is probably the spot we're going to inject it from, and we can get a little closer if we want. I'll show you guys a little technique here, and then we'll do another run. So let's get the wire. If you don't have a balloon catheter, one way to try to get a little bit more distal perfusion is to take the base catheter and sort of just try to spasm the origin of the prostate artery. And we're very close to the origin with the base, and so that's a really effective technique when you have type 4 origin like that.
Aaron, when you're seeing the flow through here, even though it's so delayed, what about giving nitro-verapamil here? What do you think about that?
We're going to get
this out.
Yeah.
You want to get a little more distal before you do that?
I think, I mean, it doesn't really matter, but we should definitely give nitro. And nitro does two things, right? It gives you probably more room to, that roadmap went away, but that's okay. Let's turn the roadmap off. It gives you the ability to sort of reverse flow in those pudendal collaterals, and it opens up some of the arteries within the gland itself. And so now that I have the wire in the prostate and the catheter in the prostate, I can sort of just take the base catheter from the wrist and I can just sort of get it as far. I mean, we're probably in the prostate artery right now, for sure. It's so big, but this is going to help us. It's going to help us because it's going to prevent reflux. And now we're going to go to AP. We're going to do what Dan mentioned. We're going to take the wire out. We're going to put a little nitro in. And then we're going to do an AP run because we really want to see, and we want everybody to see, how much this is perfusing the opposite side, which it's definitely more than half.
That's all titled.
You guys agree?
Oh, for sure.
Yeah. Now, people always ask about non-target. Wow. That's the whole prostate.
That's beautiful.
Yeah, that's pretty much the whole thing, right?
Yeah.
Yes.
So what we're going to do now is we're going to go over to, I don't think we need to embolize that other vessel, honestly, because that was more of a waste of time than anything else. But you can see the bottom part of the prostate where the pena cava was supplying it is being fed through the gland itself. So we should be able to, if we're lucky, get glue over there. Let's walk over to the embolic table. And if you guys can take a look.
That's a great angio.
It's the one you always hope for doing these cases. Yeah.
That's beautiful.
Can you guys see the embolic table? So in the little beaker here, we have a half cc of n-BCA. I took out a little extra oil, so 1 cc of oil. Now we use this to flush the catheter. And so the standard technique, if we're going to reuse the microcatheter, whether it's a balloon or an end hole, is we flush the dead space first with the oil after the glue. Then we reflush it with D5W. And then we put the wire through to clean it. And that allows you to reuse the catheter in 99% of cases. This is basically 5 cc's or 4 cc's now of oil. We're going to mix that with half cc. So you can do the math. It's 8 to 1. We're going to mix that up. And we're going to take 1 cc aliquots. Is this what you do, Viv?
Yeah. Aaron, I'm wondering about in cases where, later on you were using particles plus coil. In those instances, when you have redo, is it usually because of failure of the coil and you're treating through it with the liquid or a collateral supply? Or
say that one more time, Viv. I missed it.
Sorry. In this case, you didn't put coil into the prostatic artery, but in cases where so
we were doing
that
for a while, and what we were realizing, we realized 2 things. Number one is it probably didn't change outcomes too much, which that's like probably the most important thing. But when we did redos on those patients, the coils were not that helpful. We would go right through the coil mat,
just like
and not it depends. I mean, if you put really dense small coils in, you probably get occlusion, but there was many cases where we put maybe 2 coils in and it just wasn't really that effective. And so, glue sort of doesn't have that issue, right? Glue's permanent embolic and you're done.
So do you want to do this injection AP or do you want to do the angle for the glue?
I'm going to probably do it with the angle, and I'll explain why in a second, but I'm going to flush 3 cc's of D5 right now.
Let's bring you back over here.
And we're going to go back to the oblique. So a lot of people don't like to push hard with the glue, and that's, I think, a big mistake. We do have protection above with that base catheter. We just want to try to avoid some non-target here. If we get non-target down the pudendal, and that does happen in some cases, it's very rarely it's going to make its way all the way into the penis to cause an issue, or the cavernosa artery. So if you get some non-target off the back of the pudendal branches, you're not going to be in terrible shape. But so I'd rather see more distal penetration and go that route than go too slow. So here's the injection here. So I did that first CC very fast, and now we're going to keep going. And that's it. So we pretty much filled the entire prostate, it looks like, including that branch down at the bottom.
That's right.
So you see how the glue is still moving? That means that it's not set yet. So what I typically do is take the base catheter and remove it or pull it back away from the origin. So when I pull the microcatheter out, it's not going to trap glue inside the base catheter. Do you guys see that?
Mm-hmm.
I'm going to take a 1X here. And so that's a great example of how we actually filled that pinna cava branch that we were trying to get into before. So we basically occluded the entire prostatic circulation.
Let's take a look
at a more permanent way. And so I think, a lot of us are like, well, is this really better than particles? Well, it's faster. We know that. We know it's less dose. I mean, we've been messing around in 15 minutes of fluoro time, and our dose in here is 309 milligray, which is not only a testament to glue, but it's also a testament to this Siemens Icono room. I'm going to pull the catheter out because I've been talking for a while. So it's been in there for a little bit. So I'm going to just pull, and it should come right out. There you go. So I wanted to leave it in for a few reasons. I wanted you guys to see how long you could leave the catheter inside, but also I didn't want the glue to be super liquid that when I pulled it, it would drag itself back. But that was actually a really good result. What do you guys think?
Yeah. That's great. I mean, you got both sides there, and you can even see it tracking out the other side, and we didn't get any type of distal penetration that I think anybody would be concerned about.
And there's absolutely zero non-target here.
Yeah.
Yeah, that looks
But the key
fantastic.
to that penetration was absolutely the rate at which you injected.
And you saw how fast we went, right?
Yeah, exactly. That's my point, is that, you are sort of semi-occlusive with the spasm around the base, and you're kind of getting that distal with that speed that you use to inject.
Well, we're actually in the gluteal there. We're going to do another run. I just want to make sure there's no pudendal. See if I can move it over the pudendal. There we go. We're going to do a run here. Yeah. So it doesn't even look like that pinna cava is even supplying the prostate anymore. You can see the anastomosis with the obturator. You can see the dorsal penile artery.
And when you look at the cast, I think you can see very distal penetration inferiorly there.
Yeah.
That's great.
Yeah, you covered the bottom, had the inflow. That's fantastic.
Yeah. Yeah. So, cone beam CT, we can talk about that for 1 second. I don't think in cases like this, it's necessary because it's not going to change what I do. I find cone beam CT to be useful if it's going to alter my plan or change the trajectory of the case. I don't find it that useful at this point after seeing so many anatomic origins that it helps me identify the vessels anymore. It can be used to determine coverage of the prostate if there's other vessels that you may have missed to try to find them. But I think based on these angiograms, and if you study them long enough, it becomes very clear where the reperfusion of the prostate comes from. I think number 1, pinna cava. Number 2, umbilical artery. Number 3, SVA / retropubic branch of the obturator. Did I miss anything?
That's exactly right. I think cone beam is good when you're really starting out and you don't know the anatomy. It's very helpful to confirm what you're thinking, but the challenge is it's a static image, and you learn so much from the dynamic flow and the angiography. You might get fooled in thinking you're safe, and then you start to embolize, and You're not getting a good run that shows you all the collaterals like this patient had that goes other places. You might miss that with the cone beam and a power injector at a very low flow rate. You would not have seen the pinna cava branches.
Yeah, absolutely. So the final dose here is 330 milligray salmon viv, and we got 15.6 minutes of fluoro time. And obviously we were doing a lot of runs, but that's I think a testament to the Icono room. Dan and I have been using this for all of our prostates and knees over here. It's been quite remarkable. When you compare the dose on the Icono to the room across the hall, which is the Artis, and we're doing a clinical study now to compare the doses with equal fluoro times, it's remarkably different. So much so that I don't even want to do them in the other room anymore.
Well, I mean, what's amazing is the image quality. I think a prostate is one of the hardest procedures for a machine to do, to image over the pelvis, 35, 40 degrees in an American-sized male, and to have good image quality and low dose. I mean, that's what you're looking for. Imaging over a knee isn't hard. Doing that with a low dose isn't hard. Doing a prostate is the challenge. And the doses here are exceptionally low.
We're also upgrading. I think there's an optic AI upgrade, which is going to lower the dose even more over the next few weeks.
Very excited to see how that works.
Yeah, this is for prostates where your doses can be a little bit high. This is just pretty game changing. Do you guys want to see anything else? Because I think we're done.
Yeah.
Do you guys have any questions?
Great outcome. And
A good question I will ask you, Aaron, since we have a couple of minutes. Do you change how you approach your repeat patients, like in terms of your workflow and what you interrogate over your regular de novo patients?
Yeah, that's a great question. So, the 4 vessels that I mentioned, I always look at primarily. I mean, you want to make sure that the prostate artery is open or closed. And obviously in this case, one was open, one was closed. But then pinna cava, always look at that. Always look at the umbilical. Always look at the retropubic. I mean, you look at everything really. But the other things to consider that are a little bit less common are the IMA through the superior rectals, retrograde into the middle rectal. You also can see middle rectal branches that give rise to the posterior lateral prostate, which ultimately supplies the gland after the fact too. And so it could be middle rectal or superior rectal. I don't see IMA very often. I think I've only seen it 2 or 3 times. But the other option is to look at the profunda artery, because there are rare cases where obturator branches and prostate arteries can come off profunda. Is there anything else that you guys have seen?
I have seen the IMA one, which is terrible.
Yeah, I've seen IMA twice, and that's the instance where the pre-op CTA was kind of really helpful for me to suspect it and then confirm with cone beam. So that's like the scenario where cone beam would come into play for me.
Yeah, absolutely.
The only, looking at how much do you interrogate the pre-op CTA? I look a lot, probably too much, but in this case, probably I would suspect that the left was the dominant supply just from that, given the overall size of the prostatic artery on the left side that you saw. So maybe going there first would cut down a little bit of fluoro time, but.
Let's zoom in on the wrist.
Yeah, I didn't get a CTA in him because he was 9 years, and I knew that we would have at least one prostate artery open. But getting a CTA to plan a redo is completely reasonable. I do think sometimes you get, at least in this case, I don't think it was going to be that useful, but it can be useful if somebody has recurrence sooner than 9 years, maybe a year, 2 years later. It's possible that you just missed a small vessel that just hypertrophied.
Yeah, you can see that hypertrophied vessel sometimes.
And for the de novo ones, it's super helpful just to know whether they have, athero occlusion of the internal, and that you're getting off the bat.
Definitely.
That you're going to have.
How much of a battle are you signing up for?
Can you guys zoom in on the wrist real quick, and we'll put the TR band and then we'll be done. Okay. So we pull the sheath back about an inch and we wrap it, the green dot you guys can see. Let's zoom in on that a little bit better. Refocus it if you can. Thank you. You guys can see that. It's a little, okay.
There you go.
And then 15 cc's of air, sheath comes out, and we take a little air off the back. We see it bleeding a little bit. We put one or 2 cc's back in, and he has a very good radial pulse now. So he has patent hemostasis. And so that's it. We're going to leave the TR band on for an hour, and then he's going to go home. We're going to give Medrol dose pack, Peridium, and Bactrim, and we're going to see him in the office in 6 weeks. Thank you, everybody. I really want to thank the techs and the nursing staff and our anesthesia support. And Sam, thank you so much for getting up early in Chicago at 8 o'clock. Thank you.
Thank you for having me.
Great case, Aaron and Dan. Thanks for sharing.
See you
Have a
guys.
great day, everyone.